Welcome to the deep dive. We cut through the noise, get straight to the insights, the things that really make you well informed. Today, we're plunging into something that, well, it affects millions of us, right? Directly, or maybe someone we care about. It's the intricate world of our joints. We're doing a deep dive into concepts of care for patients with arthritis and total joint arthroplasty, our mission, to pull out the most crucial nuggets of knowledge. About different joint conditions, their causes, symptoms, sometimes surprising ones, and how they're managed, even surgery.
It's true. These conditions are incredibly widespread. They range from, the common wear and tear that many people experience,
Yeah.
all the way to much more complex autoimmune responses. The real key, I think, is understanding the fundamental differences between them. That's crucial for grasping how they affect the body and, importantly, how they're treated.
Absolutely. And by the end of this, you're going to have some real aha moments, I think, about what truly impacts our joint health and maybe how interconnected our body systems really are. Okay, let's kick off with osteoarthritis, OA, often called the wear and tear type, right? So basically, it's the progressive deterioration, the loss of cartilage in joints. But what actually happens when that cartilage goes? It's more than just friction, isn't it?
Right. It's not just friction. You get the joint space narrowing. The natural synovial fluid, which is like the joint's lubricant, that decreases. You can even get calcifications forming. And sometimes little pieces of bone or cartilage float around in the joint. That causes crepitus.
Ah, crepitus, that distinct grating or crackling sound. Yeah.
Exactly. And OA is by far the most common type of arthritis. You'll often hear it called degenerative joint disease, or DJD. It typically hits weight-bearing joints, hips, knees, but also the spine and even the hands. A key thing is it's often unilateral and asymmetrical. So you might have it in one knee but not the other, or worse in one hand. It's more localized.
So it's not just about getting older. What else makes some people more prone to OA or affects certain joints more?
Well, aging and genetics are definitely primary factors, yeah. But secondary causes, like a past joint injury or obesity, they can really speed things up. They increase the wear and tear. That's why some athletes, like professional athletes or even gymnasts, runners, they're at higher risk. It's that repetitive stress over time.
Okay, so that repetitive stress really adds up.
It does. So for health promotion, it's really about protecting the joints proactively. Things like maintaining a healthy body weight that directly reduces stress on knees and hips. Also being mindful of activities that put a lot of strain on joints, taking breaks during repetitive tasks, wearing supportive shoes, really avoiding trauma and repetitive stress where possible.
And when someone does start getting OA, what are the telltale signs besides the obvious pain and stiffness?
Well, you mentioned crepitus, that grating sound. You might also see the joint looking enlarged, maybe due to excess fluid. We call that joint effusion. Sometimes muscle atrophy, where the muscles around the joint get weaker. Extremity pain is common. And in the fingers, you might see those bony bumps called Heberden's nodes. They're basically bone spurs forming where cartilage has worn away.
Heberden's nodes, right. Very characteristic.
Yeah. Diagnostically, lab tests are usually normal or show just a slightly elevated ESR. That's the erythrocyte sedimentation rate. It's a general inflammation marker, but it's typically not high in OA because it's more mechanical. X-rays are really key. They show the structural joint changes, the narrowing space. MRI might be used for, say, vertebral or knee issues to get more detail.
Okay, so once it's diagnosed, what does this mean for living with OA? How do you manage the pain?
Pain management is huge, obviously.
Right.
The goal isn't always zero pain, but getting it down to a manageable level, maybe a 3 or 4 out of 10. Acetaminophen is usually the first thing doctors recommend. Other options, topical things like lidocaine cream, Voltaren gel, NSAIDs like ibuprofen, of course. For more severe pain, sometimes tramadol, maybe even opioids or medical cannabis are considered. Some people try dietary supplements too, like glucosamine, chondroitin. But really, it's not just meds. Rest, the right kind of exercise, and complementary therapies, they're all important pieces.
And managing it day to day out in the community.
Yeah, community-based care is vital for the long haul. This might mean having a home health nurse or aide visit, maybe making changes at home like adding grab bars or ramps for safety. And health teaching is absolutely critical. Teaching patients the right exercises, how to limit repetitive stress, how to listen to their pain, not pushing through it. Using resources like a case manager, getting clear written instructions, all that helps people manage successfully at home.
Okay, so that covers managing OA. But sometimes the damage is just too much, the pain is too severe. That's when surgery, total joint arthroplasty, or TJA, might be the answer, right? Rebuilding the joint.
Exactly. TGA is about creating a functional artificial joint using implants. The main goals are relieving that severe pain and restoring mobility. The most common ones are total knee, total hip, and total shoulder replacements. One really crucial point. Surgeons absolutely will not do this surgery if the patient has any active infection anywhere in their body. It's a major safety rule. Besides severe OA, another reason might be osteonecrosis, that's bone death from lack of blood supply. And we talk about primary arthroplasty, the first replacement versus revision, which is when an existing artificial joint needs to be replaced.
Got it. Let's focus on total hip arthroplasty, THA. Preoperative care, the prehab, a lot of teaching happens before surgery, doesn't it?
Right.
What's the absolute key thing patients need to grasp beforehand?
I'd say the most crucial thing is setting really clear, realistic expectations for right after surgery. Understanding the pain management plan, knowing how they can actively help prevent serious things like blood clots, VTE, or infection, and knowing what to expect mobility-wise right from day one. We teach them safe ways to get in and out of bed, how to position themselves, what the walking goals are, nutrition too. It empowers them.
Makes sense. And during the surgery itself, what should patients know?
Well, they get antibiotics beforehand, super important for preventing infection. Anesthesia varies, could be general, a regional block, sometimes a mix. Increasingly, we use a medication called tranexamic acid, TXA, during the opus to reduce blood loss quite significantly. And many hip replacements now are done with minimally invasive techniques, smaller incisions, potentially a quicker initial recovery.
It's fascinating how the surgical approach itself can make such a difference. You mentioned different ways to do a hip replacement.
Yes, that's a really big deal now. There are three main approaches. The anterior approach often means the quickest recovery and the lowest risk of dislocation because the surgeon doesn't have to detach major muscles around the hip. Then there's the direct lateral approach and the posterolateral approach. This one traditionally has the highest dislocation risk because major muscles often are detached or cut. It can also mean more post-op pain, so the approach really impacts the recovery path.
Right. So after the surgery, what are the main complications everyone's watching out for with THA?
Okay, the big ones are thromboembolic complications. That's DVP, deep vein thrombosis, or PE, pulmonary embolism, which is a clot in the lungs. Then there's postoperative infection and dislocation of the new hip joint. Sudden intense pain is often the first sign of that.
Dislocation sounds scary. How is that prevented, especially with those approaches that have a higher risk?
It requires careful management, especially with the posterolateral or lateral approaches. The key is keeping the legs abducted slightly apart, often using pillows or a special abduction pillow. A trapeze bar over the bed can help patients move safely. Critical rules: no crossing the legs and being very careful about sitting positions, not bending the hip too much. Hospitals have strict protocols for turning patients safely.
Okay, and preventing those other things like blood clots and infections.
For blood clots, VTE-DVT, patients usually get anticoagulants, blood thinners for about 10 days after surgery. Things like enoxaparin, rivaroxaban, apixaban. If it's warfarin, they need regular blood tests, PT-INR, but meds aren't enough. Early ambulation, getting patients walking as soon as it's safe, is vital, plus simple exercises like quad sets. For infection, we watch closely for fever, increased redness, or any unusual drainage from the incision, and of course, managing pain effectively helps everything else. The overall goal is to get the patient home safely as soon as possible, maybe with a case manager coordinating community support if needed.
All right, let's switch to total knee arthroplasty, TKA. Pre-op care sounds pretty similar, lots of teaching beforehand. What about the surgery itself and the key differences in post-op care for knees?
Yeah, pre-op is very similar. For the knee surgery, options range from traditional open surgery to partial knee replacements, and also minimally invasive techniques. Post-op care has overlaps with hips, DVT-PE prevention, usually anticoagulants for maybe 14 days for knees, infection watch, and careful neurovascular checks of the leg and foot. Interestingly, knees might have less blood loss than hips sometimes, but the post-op pain can actually be more intense for many patients.
More pain, really. Okay. So what are the big differences after knee replacement?
The main difference is the focus on mobility goals. We aim for functional walking and getting the knee to bend to 90 degrees. Physical therapy supervises this very closely. Sometimes a continuous passive motion, or a CPM machine, is used, though less often now. It gently bends and straightens the knee. PT usually sets it up. Peripheral nerve blocks, PNBs, are common for knee pain control. Neurovascular checks, checking circulation and nerve function in the foot, are done very frequently, maybe every couple of hours initially. Unlike hips, you don't need special abduction pillows for knees, but it's really important to keep the knee flat on the bed when the CPM isn't on. And definitely don't hyperextend it, don't push it backwards.
Good to know. Any quick notes on other joint replacements?
Sure. Total shoulder replacement rehab usually takes about 2-3 months, focusing a lot on preventing subluxation or partial dislocation. Total elbow replacement can involve swelling for quite a while, maybe 3-6 months. And yeah, even smaller joints like fingers, toes, and ankles can be replaced, though it's less common than hips and knees.
Okay, we've covered wear and tear, and we've covered replacing joints. But what if your own body is the problem? What if it attacks your joints? That brings us to rheumatoid arthritis, RA.
Exactly. RA is totally different. It's a chronic, progressive, systemic inflammatory autoimmune disease. It primarily affects the synovial joints. What's happening is the body's own immune system, through things called autoantibodies, mistakenly attacks healthy joint tissue. That causes widespread inflammation.
So comparing it back to OA really makes the difference clear, doesn't it?
It really does. RA typically hits younger people, often 35, 45 years old. It's more common in women. It's fundamentally autoimmune and inflammatory. A key feature is that it's often bilateral and symmetrical, affecting, say, both wrists or both knees, often several joints at once. And lab tests show those specific markers: positive rheumatoid factor, ANA, elevated ESR. Completely different picture from OA, which is degenerative, usually one-sided, affects older folks, and lacks those autoimmune markers.
Okay, so how does RA actually damage the joints? What's the mechanism?
Well, it involves inflammation and degeneration of the cartilage, similar to OA in outcome. But the driver is the immune system attacking it. And because it's systemic, it's not just localized. It can affect the whole body, leading to multi-system issues. This ongoing immune-driven damage can cause significant joint destruction and immobility over time.
So if it's autoimmune, what triggers it? Why does the immune system turn on itself like that in RA?
That's the million-dollar question, and honestly, the exact cause is still unknown. It seems to be a mix of things: environmental factors, genetics, hormones might play a role, maybe even certain infections. There's some research linking it to viruses like Epstein-Barr. What we do see clearly is that stress, both physical and emotional, often triggers flare-ups or makes symptoms worse.
That stress link is interesting. What does RA actually look like for someone experiencing it? What are the symptoms, especially early on versus later?
General symptoms include significant pain, joint swelling, limited movement, stiffness, especially that awful morning stiffness that can last for hours. Plus, systemic stuff like weakness and really profound fatigue. Early on, it's often that morning stiffness, swelling, pain, maybe a low-grade fever, fatigue, weakness, loss of appetite. Upper joints, especially hands, often get hit early. They might look a bit red, feel warm, stiff, swollen.
And as it progresses,
Later on, the joints become more inflamed, often leading to visible deformity. Pain can become moderate to severe, and that morning stiffness persists. Systemic effects also get worse: severe fatigue, anemia, weight loss, osteoporosis, those little subcutaneous nodules under the skin. You can also see neuropathy, vasculitis, inflammation of blood vessels, even pericarditis, inflammation around the heart. Other late things include effusions, more joint deformity, and sometimes Sjogren's syndrome, which causes really dry eyes, mouth, and other tissues.
wow, that sounds incredibly tough to live with. Given all that, how important is the psychosocial side of things, dealing with the emotional impact?
Oh, it's absolutely critical. Just as important as the physical symptoms. Imagine chronic pain, unpredictable flares, changes to your body. It leads to fear, altered body image, frustration, depression. It impacts mobility, doing daily activities, causes extreme fatigue, hits self-esteem hard. Feelings of helplessness are common. Addressing the mental and emotional side is a huge part of care.
Makes total sense. How is RA actually diagnosed then? What do the labs show?
Key lab findings include a positive rheumatoid factor, and especially anti-CCP, that's anticyclic citrullinated peptide, which is very specific for RA. ANA, the anti-nuclear antibody, is often positive too, and you'll see elevated ESR and C-reactive protein, those general inflammation markers.
And imaging. What else helps confirm it?
X-rays show bone and joint changes over time. CT scans might be used for the neck. Bone scans can show widespread inflammation. Sometimes arthrocentesis is done drawing fluid from a joint. That fluid can be analyzed for inflammatory cells and immune complexes. It can also relieve pain by reducing pressure.
Okay, let's talk treatment. It sounds like it needs a pretty robust approach.
It does. Medications are key, often aiming to slow down the disease itself. The main category is DMARDs, disease-modifying antirheumatic drugs. Methotrexate is usually the first-line DMARD. It's an immunosuppressant taken once a week, usually low dose. Takes 4-6 weeks to start working. Important points about methotrexate: it can cause birth defects, so contraception is vital. And it lowers white blood cell counts and platelets, decreasing immunity. Other DMARDs include leflunomide and hydroxychloroquine.
And then there are the biologics, right? Those sound more targeted.
Yes, the biologic response modifiers, or BRMs, these are newer drugs, often very effective. They target specific parts of the immune response involved in RA. Think etanercept, infliximab, adalimumab. There are quite a few now. Most are given by injection or infusion, so patients need teaching on how to self-administer if applicable. Sometimes they're used in combination with methotrexate. The big caution with BRMs, like other immunosuppressants, is the increased risk of infection, so patients need to be vigilant. Other drugs used might include glucocorticoids like prednisone, usually for flares, and basic pain relievers like Tylenol.
What about non-drug approaches, things people can do themselves?
Adequate rest is crucial because fatigue is such a major issue. Proper positioning to protect joints, guided by PT, is important. Ice and heat applications can help with pain and stiffness.
Anything more advanced or complementary?
In severe cases, plasmapheresis plasma exchange might be considered. Gene therapy is still experimental, and many people explore complementary therapies like hypnosis, acupuncture, imagery, trying to find extra ways to cope and manage symptoms.
And for promoting mobility, just general care, what's the focus?
It's really about supporting independence, encouraging the person to do what they can for themselves. Little things like helping open packages in the hospital, yeah, but also recommending assistive devices for home ramps, grab bars, raised toilet seats, and encouraging that balance between rest and activity. Gentle exercise is important, but avoiding overdoing it. A lot of the nursing care principles are actually quite similar to what we see in lupus, which is another systemic autoimmune condition.
All right, let's shift again. We've done wear and tear, autoimmune. Now let's talk gout. Another type of arthritis, but with a totally different cause, right? Crystals.
Exactly. Gout is systemic, and it's all about urate crystals. These crystals deposit in joints and other tissues, and that causes intense inflammation. It's linked to hyperuricemia, having high levels of uric acid in the blood. It causes these severe, recurrent attacks of arthritis, often comes on very suddenly. While it's usually not life-threatening itself, those attacks are incredibly painful. It can become chronic and quite disabling if not managed.
So, uric acid crystals, what makes them form? What kind of foods or habits trigger a gout attack?
Well, diet is a big factor for many people. Foods high in purines can increase the frequency of attacks because purines break down into uric acid. We're talking things like anchovies, sardines, herring, mussels, organ meat, liver, kidney. Also some vegetables like mushrooms, asparagus, peas, beans, gravies, broths too. Alcohol, especially beer, is another major trigger. It can hamper the kidney's ability to get rid of uric acid, leading to buildup.
Okay, so diet and alcohol are key triggers. How is gout diagnosed then?
A consistently high uric acid level in the blood, usually over 6.5 milli-GDL, is a big clue. Doctors might do a 24-hour urine collection to see how much uric acid is being excreted. Checking kidney function BUN and creatinine is important too. But the gold standard, the definitive diagnosis, is synovial fluid aspiration. They draw fluid from the inflamed joint and look for those urate crystals under a microscope. ESR will likely be elevated during a flare because of the inflammation.
And medications for gout, what's used?
There are meds to lower uric acid levels long-term to prevent attacks. Probenecid helps the kidneys excrete more uric acid. Allopurinol is very common for chronic gout. It reduces uric acid production. Then, for treating an acute attack when it happens, colchicine is often used to quickly reduce that intense pain and inflammation.
Okay, our final deep dive for today takes us back to the autoimmune realm, but with a different condition. Systemic lupus erythematosus, or SLE, another chronic, progressive, systemic inflammatory autoimmune disease.
That's right. SLE is complex. Autoimmune complexes form and attack various tissues. It's known for its pattern of spontaneous remissions and then exacerbations or flares. The really serious part of SLE is its potential to affect major organs: kidneys, heart, brain, lungs. That systemic inflammation and immune attack can lead to progressive tissue damage, organ failure, and unfortunately can sometimes be life-threatening.
And lupus often involves the skin, doesn't it? That famous rash.
Yes, skin involvement is common. There's cutaneous lupus, CLE, which only affects the skin. But, and this is important, a large percentage, maybe 70–80% of people initially diagnosed with just CLE eventually develop the systemic form, SLE. It shows how it can progress.
So what's going on under the hood with SLE? What causes the damage?
It seems to involve triggers things like infections, injuries, certain drugs, hormones, even UV light exposure in people who are genetically susceptible. These triggers set off an autoimmune response where antibodies attack the body's own tissues, causing widespread inflammation. A key feature is vasculitis, inflammation of blood vessels. This narrows the vessels, reducing blood flow to organs, which is a major way it causes damage.
Who tends to get SLE? Are there known risk factors?
Genetics definitely plays a part. You often see a family history of connective tissue diseases. It's also dramatically more common in women, about 10 times more than in men. Onset is often in the 40s. Environmental exposures are thought to contribute too, though the specifics are still being studied.
And the symptoms, I hear they can be incredibly varied.
Hugely varied. That's why diagnosis can take so long. Average is about 6 years from symptom onset. It can affect almost any system. Skin, joints and muscles, kidneys, leading to chronic kidney disease, heart, lungs, GI tract, nervous system. Plus, there are common systemic symptoms like persistent fever, overwhelming fatigue, loss of appetite, and that widespread vasculitis we mentioned.
So when trying to diagnose it, given that variety, what are the key things doctors look for?
A really thorough history covering all body systems is essential. A psychosocial assessment, too, because the impact is huge. Key physical signs can include that classic butterfly rash across the nose and cheeks. Extreme sun sensitivity is common. Mouth or throat sores can occur. Lab-wise, a positive ANA anti-nuclear antibody is a strong indicator of autoimmunity, though not specific just to lupus.
No single test.
Correct. No single lab test can diagnose lupus. It's a combination. Besides ANA, doctors look at ESR and serum complement levels C3 and C4, which are often low during active disease because the immune system is using them up. And they'll monitor organ function closely, kidneys, liver, heart, bone marrow, because SLE can affect any of them.
How is SLE treated then? It must depend on severity.
Absolutely. If it's just skin involvement, topical cortisone creams might be enough. For systemic disease, treatment often starts with milder drugs like Tylenol or NSAIDs for pain and hydroxychloroquine, that's an antimalarial that really helps with systemic symptoms and preventing flares. Belimumab is a newer monoclonal antibody targeting specific immune cells. For more significant disease, DMARDs like methotrexate or even stronger immunosuppressants like cyclophosphamide might be used. And for severe life-threatening flares, high-dose Dialphy steroids like Cytoxan or even plasmapheresis might be needed to quickly calm the immune system down.
And the nursing care. You mentioned it's similar to RA.
Yes, many similarities because they're both chronic systemic autoimmune conditions. Big focus on skin protection due to sun sensitivity. Hair care, too, as hair loss can happen. Patient teaching is paramount, helping people understand this complex condition, recognize flare triggers, manage medications. Connecting patients to support groups and community resources is also really important for coping long-term.
Okay, one last thing before we wrap. Fibromyalgia. It causes chronic pain, often gets confused with arthritis, but it's different, isn't it?
Very different, yes. Fibromyalgia is characterized by chronic widespread pain, fatigue, sleep problems, brain fog. But it is not an inflammatory disease. It doesn't cause joint damage like arthritis does. It involves specific tender points, often described as a burning or gnawing pain, muscle tenderness. It's thought to be more about how the central nervous system processes pain signals, a disorder of pain amplification, essentially.
Right. And there's that acronym to remember the symptoms. Fibromyalgia. Fatigue, irritability, brain fog, restless legs, overlapping syndromes, muscle and joint pain. You're energy drained, anxiety and depression, loss of control, grief and worry, immune dysfunction, though not autoimmune in the same way, and a persistent struggle. Hashtag outro binner.
Wow. What an incredible journey through the very complex world of joints and connective tissues today. We went from osteoarthritis, that wear and tear story, to the big autoimmune battles like RA and lupus. We hit gout with its crystals, talked about replacing joints with TJA, and even touched on fibromyalgia. Quite a range.
It really is. And I think the big takeaway is how these distinct processes, mechanical breakdown, autoimmune attack, crystal deposition, lead to such different symptoms and, crucially, need such different tailored approaches to care. Understanding that why is so important.
So thinking about all this, what does it mean for you listening? We hope this deep dive helps you understand your own health better, maybe ask better questions, feel more confident talking to doctors, whether for yourself or someone you care about. Absolutely.
Yeah.
And just keep thinking critically. Consider different perspectives when you hear health information. These systems in our body are just so interconnected.
Exactly. So maybe just a final thought to leave you with. How might really grasping the body's intricate connections, like we saw with these joint conditions, how might that change how you think about your own wellness, about being proactive with your health every day?